I'm sorry. Usually we're in there, but I don't know. Yeah, I'm not sure. Hey, where are you?
Do we have Dr. Toshani yet? Toshani?
I'm here right now.
Okay, very good. So it sounds like we're ready to go. I'm just going to start out and pass it on, if it's okay, Carlos, to our co-moderators. My name is Jose Pascual. The reason it's so difficult to get onto this platform is because there's higher levels of security. This group has been hacked multiple times in the past, so thank you for your patience. In general, the only people that can share video and audio are those that are panelists, presenters, or moderators. If you have comments, though, please put it in the chat. And our two moderators today, Carlos from the Pan American Trauma Society and Randeep from the AAST, the American Association for the Surgery of Trauma, are going to monitor that. And with that, if you have any interest in presenting a case or being a panelist for a case in the future, please reach out to either Carlos, Antonio, or myself. The email's on the flyer. Carlos and Randeep, all yours.
Perfect. Dr. Randeep, do you want to start with the WST case?
Okay, sure. So for AAST, we have Dr. Tosani presenting from the Riverside University Health System. He's a fellow in surgical critical care, and his faculty, Dr. Agapian, and I believe Dr. Edwards are also on. So go ahead, Dr. Tosani.
Okay, perfect. Thank you for having me. Let me just, can everyone see everything okay?
Yeah, Dr. Tosani, just a second. Let me just take the opportunity to introduce all the panelists that we have. So we have Dr. Michael Moncure, who will be joining us in a second. He's a professor of surgery, Kofi Endow's chair, UMKC, Associate Trauma Medical Director and Vice Chair of Surgery at the University of Health, Truman Medical Center in Kansas City. We also have Dr. Dinesh Bagaria with us. He's additional professor of surgery, Division of Trauma Surgery and Critical Care, Apex Trauma Center, New Delhi, India. And we also have Dr. Tanya Zachrinson. She's a professor of surgery at the University of Chicago. The three panelists will be joining us to discuss both cases. Thank you very much. Dr. Tosani, you may move on.
Perfect. Hi, everyone. Thanks for having me. So the first case we're presenting is a 36-year-old male who presented with unknown past medical history via ambulance after having a stab wound to the right chest, right parasternal border. Report per EMS, he was found walking on the road. He was covered in blood, initially combative, requiring multiple people to kind of calm him down. And then at the scene, they saw blood in the stab wound. 2 minutes prior to arrival, he became hypotensive, unresponsive. His vitals on arrival are as listed: tachycardic, hypotensive, GCS3. And what you can see here is a picture of what the stab wound looked like. It was pretty large, about 3 or 4 centimeters, and this would be the right parasternal border. At this time, what do you guys think in terms of differential? What are we most concerned about?
Why don't we start with Dr. Bagaria? How would you evaluate this?
I'm concerned about the reporting of the GCS3. I mean, how we can report a GCS3 in a patient when we are thinking that it is vitally unstable, but he was walking. So that is probably some sort of maybe not properly reported here. But like you said, it is parasternal. So two things are coming in my mind. One thing may be some sort of cardiac injury, and the other is probably some big vessels in the chest, or maybe some lung parenchyma. As of now, with these vitals, I will go more towards a cardiac stent.
And Dr. Moncure, do you have anything additional to add in terms of your initial evaluation?
Yes, I would agree with that assessment. The other thing might be there's something causing that GCS of 3, possibly air in the coronaries or what have you. But yeah, cardiac injury is my biggest suspicion.
And finally, Dr. Zackerson.
Thank you. I agree with the other panelists. And we would do our standard ABCDEs as per ATLS protocol. We don't, tend to intubate and penetrating trauma. But my concern with this differential is clearly, a stab wound to the cardiac box, if not near, you need a cardiac FAST. But being by the side of the road, that doesn't preclude, like maybe the patient also sustained blunt traumas, could be hit by a car or something. So part of your primary survey to help me differentiate if it's purely cardiac and the GCS of 3 really is because of hypoperfusion from hemorrhagic shock versus GCS of 3 because there's also concomitant TBI from a blunt trauma I do not know about, is I would just make sure I have a pupillary exam while I'm getting blood in and doing all the appropriate maneuvers. But it is a little unusual. I agree with my panelists. Thank you.
Dr. Tasani, please continue.
Yes. So on arrival, so his airway was not protected. He had absent breath sounds on the right. He was hypotensive, had a palpable pulse, was tachycardic. His pupils were fixed and dilated. There was no rectal tone. We saw the 2 to 3 centimeter stab wound. Massive transfusion protocol was started. He received 4 units of blood, 4 of FFP. He had a right-sided chest tube place with 550 cc's of initial bloody output. He was intubated, a FAST and a chest x-ray was done. The FAST here is just the cardiac silhouette, but it's a very trace pericardial fluid, questionably. Chest x-ray here after the chest tube was placed and he was intubated. No large effusion, no large pneumothorax, cardiac silhouette, as you guys can see. Knowing this information, what's like the next steps in management? Would you want any additional information? How would you like to proceed from here?
Great. Dr. Broadway, if you want to start.
Here, I would like to know that if after putting ICD, there was change in the vitals parameters of any, because the X-ray looked quite good. I don't see any specific reason for him to be hypotensive because FAST has ruled out a reasonably obvious cardiac injury. There is no cardiac tamponade component. The lungs, both lungs fields looks reasonably pretty good. And like you said, that ICD drained 550 ml of blood. But what happened after that, whether there was any change in the vitals or not?
Okay. Dr. Moncure.
I would agree. Just what was the response to vital signs, and if he's not sedated, if he started to wake up after this?
Dr. Zackerson.
Agree with panelists. Unless there's like, even in the situation of, is there a severe TBI with, injury that I can see from the outside? This patient will die from a cardiac injury if I don't rule that out. Again, we need to know what is the response to blood. I'm happy that the patient did not arrest with the intubation, which is a possibility. A trace cardiac FAST is still positive in my view. I'd agree with Dr. Frisbee. Hi, Dr. Frisbee. Good to hear from you. I would definitely go to the OR at this point if I'm worried, like maybe there was that blunt trauma that we chatted about earlier. Maybe there is a concomitant severe TBI. I'm going to give them hypertonic saline on the way, and maybe I can hyperventilate and do all the maneuvers if I'm concerned about herniation with those fixed and dilated pupils. But that's going to be a bit of a moot point if the patient dies from a cardiac injury. So OR is the safest place for me. And if it's heavy-handed, if it's like a negative pericardial window or something like that, so be it.
Would any of our panelists take him to CAT scan right now before going to the OR or anything else with the information that we have?
Yeah, I personally don't agree with getting any CAT scan done, and I absolutely agree with the Sanya that the OR is the safest place to think about anything further for this patient particularly.
I would agree. I put a lot of stock in the initial vital signs, and I would agree with the panelists.
Great, please continue.
So at this point, we were very concerned and wanted to basically notify the operating room to proceed to set up for, operative intervention, pericardial window, sternotomy, or thoracotomy, depending on what was necessary. We got the FAST, we got the chest X-ray, the repeat vitals. Now this is about 40 minutes after arrival. His heart rate was 150s, his blood pressure is 97/52, and the chest tube output at this point, about 40 minutes later, has only been 50 cc's, no air leak, and has received no additional blood after the initial transfusion. Given this, our plan was to go to the operating room, but given that he kind of stabilized, I know he's still tachycardic, and there was something odd about the whole story and the picture, we decided to proceed with a CAT scan. Or I guess, all right. Or knowing this updated information, would anyone's management change?
So I probably want to, like I said earlier, I am probably not in good favor of getting the CAT scan done in this patient. Heart rate of 157 is quite serious point for me. And then the plan of median sternotomy is again, probably I will not agree with it. In my practice, I will go with the clamshell thoracotomy in this particular patient.
Okay. So
I'm sorry to interrupt. Randeep, is that okay if I just make a comment?
Sure, please.
Yeah, and apologies for interrupting, but it's interesting because, I agree with the presentation, like the vital signs have improved. But absolutely what Dinesh said, I agree 100%. Like, I think it's very incumbent on us as trauma surgeons to say that's class 3 hemorrhagic shock with penetrating trauma. Like it's even though it's a bit better, the patient's not stable, the patient's no longer, not in shock or anything like that. That's class 3 hemorrhagic shock. So I'm a bit dogmatic about it. We're a bit dogmatic about that, here in Chicago, but it's important, I think, for any trainees on the call to recognize this patient is still in class 3 hemorrhagic shock.
I would like, sorry to interrupt you again. I would like to differ with Tanya that it's probably not the class 3, it's class 4 shock with the heart rate of 157.
Agreed.
Yeah, I would feel a lot better with a negative pericardial window.
Okay, please continue.
So we did proceed with CAT scan. This is the initial CAT scan going down. There's a trace pneumothorax on the right side. Chest tubes otherwise in. Small hemothorax on the right side. And then this is the rest of the abdomen pelvis. What you can see basically is where the stab wound was in relation to the sternum. There was air that was tracking down pretty much through the pectoralis muscle. There was a trace pneumothorax on the right-hand side. And then there was residual hemothorax as well. From at this point, his vital is about 1 hour from arrival. Again, no additional transfusions, no additional products. He got his heart rate is 166, his blood pressure 102/53. Initial labs that just resulted. Initial otherwise lab work. His lactate was 20. His CK was mildly elevated. And the rest as listed is alcohol was positive. UDS was sent, is pending at this point. At this point, I know everyone would have proceeded to the operating room, but what do we think in terms of diagnosis, differential, knowing we have the CAT scan, knowing the updated vitals and the patient's current status?
Panelists?
At this point in time, I also now started thinking about some sort of cardiac injury, which is not causing the pericardial tamponade, but some sort of conduction problem, maybe with the heart. I'm not sure, but still my preference would be to go to OR and open up with this patient and ruling out at least the cardiac tamponade.
Yeah, and I think I'm channeling Dr. Frisbee through me, or we could just tag team it up here because You know, the patient went for a CT scan. Thank you for those images, but I would be most interested in his head. I can't rely on CT scan to rule out cardiac tamponade or, well, even some hemopericardium, because if it's minimal, I'm still doing a window. I'm still going to the OR. But I would be interested to know what his head CT looked like. But one thing to add to Dinesh's thoughtful comments is, and this really, really depends on what kind of institution you're at. So it's, you know, this is like a high technology, high resource thing, but the benefit also sometimes of going to the OR, if it's possible, is grabbing one of the cardiac anesthesiologists and doing a transesophageal echo to get that good information, Dinesh, of, you know, what's going on with the heart. Is there some sort of cardiac dysfunction, which maybe is not notable by doing the bedside POCUS or a FAST, but that might help. But I'd love to see the head CT if for whatever reason this patient got caught in the CT scanner. Thank you.
So Tanya, if he had the TEE and it showed no effusion, would you still do the thoracotomy or sternotomy?
I'm doing a pericardial window regardless, but it's more to explain like, why? So if my pericardial window is negative, meaning there's only clear serous fluid coming out, I have to be careful that there has to be fluid coming out, because a dry pericardial window is still positive for me. But the transesophageal echo at that time wouldn't be for effusion, it would be for cardiac function. But a great question, Randeep, thank you.
And Mike, any thoughts?
I would again, I'd be worried about some kind of coronary or something causing, cardiac dysfunction. And I would agree with TE would be very helpful in this setting. The other thing I'm concerned about is that temperature being so high and a lactate being so high. Is this something weird? What did we use to induce this patient?
He had etomidate and rocuronium.
Okay.
And then the CT head was negative as well. There was no signs of trauma, no signs of edema, no signs of shift.
And nobody would assume that the FAST was a false positive in the sense that it was actually fat that was being seen as opposed to fluid, and would still proceed with a minimum pericardial window regardless. Everybody from the panelists? Yes. Okay.
Yes.
Okay. All right. Please continue, Dr. Tassani.
So at this point, we did IV fluid resuscitation, got admitted to the ICU. His UDS came back. His methamphetamines was positive. Over the first 24 hours, his CK was rising. His lactate was downtrending with resuscitation. His troponins initially elevated to 745 and then downtrended. He had marketed AST, ALT elevation, degree of shock liver. His hemoglobin remained stable at 16 on multiple rechecks throughout the hospital course, but he remained intermittently febrile, and borderline tachycardic, but blood pressure stable. His echo TTE was done, showed EF of 35 to 40%, diffuse hypokinesis, but no acute wall motion abnormality. Knowing this initial information, anyone have thoughts on diagnosis or how would they manage this?
Panelists?
To be honest, this is sort of getting, into the realm of, is there some toxicologic, or is there some sort of intoxication? How positive were the amphetamines? Can amphetamines do this? Is there rhabdomyolysis? That type of thing. So now you're putting your intensivist hats on. Also, although it does look like there's a pan-systemic shock liver, shock organ, shock kidneys issue going on we see this sometimes from the hemorrhagic shock that he had, but there's something else at play here. So it'd be just a standard kind of resuscitation protocols. And this is where I would personally rely heavily on my pharmacist to, let's look up amphetamine responses. Does this fit with something after doing a full body compartment check and just making sure there's no tight compartments? It sounds like he was, John, if I remember correctly, he was walking at the side of the road. He wasn't found down at the side of the road. So he shouldn't really have compartment syndrome anywhere, but you just want to rule that out and check everything. And there's great comments, by people in the chat as well. But this is where I would get all the ICU big brains together and say, hey, what's going on? Because this is now trauma plus something else. So let's sort that out.
Agree completely.
I completely agree with the Tanya comment that probably now our intensivists have to come into the picture more.
Mike?
I would agree completely. I'm trying to remember if there are panels for malignant hyperthermia, or one of our people in the chat talked about dantrolene or something. But this is something other than hemorrhagic shock causing this. This is either some kind of metabolic cause or yes.
Dr. Sani?
Yeah, so that was our concern. So he got dantrolene for potential malignant hyperthermia. He eventually required a tracheostomy after multiple reintubation. He self-extubated and then had hypoxic respiratory failure and then had a prolonged hospital course about 30 days. Eventually, he was decannulated. He was discharged home. The suspect was sympathetic toxicity secondary to methamphetamine use. Giving his initial presentation, all of us were planning to go to the operating room. We're concerned we want to rule out cardiac injury. But given just something was odd about the pictures where it led us down the CAT scan route and led us down this route where we ended up. And then that's all I have. Thank you guys for allowing me to present. Any questions?
Very neat. Panelists, do you have any other comments on this highly unusual presentation?
It was quite unusual presentation, I would say, and very great save, very great use of resources, whatever they have, because I personally don't think that I would have done nothing less than a thoracotomy in this particular patient. It would have been negative, but still I would have gone with the thoracotomy so far.
I agree. Very interesting case. Good job.
Yeah, I agree. Excellent case, excellent presentation, and again, cardiac pericardial window, just to roll that out, but really interesting case and excellent presentation. Thank you.
At this point, I would like to have comment from any of the panelists or presenter that what frequently you guys come across these kind of situation where the drug abuse is kind of mimicking these hypertensive or any other syndromes, which generally we see with the trauma. Tanya, anything in your experience so far?
I think Jose has his hand up.
Randeep, thank you. I just wondered if it is neuroleptic malignant syndrome that we were worried about here, or malignant hyperthermia. I think those are quite distinct issues, and how they respond to dantrolene is different. But I agree with Michael that with the original fever being that high and the induction agents as well as lack of inhalational agents not really being the source, I would wonder if that worked. Did the jaw get locked then released or not? And then I would argue that once I saw that CAT scan with no evidence of fluid around the heart, that I don't know that I would rush to the operating room anymore. With a negative FAST that has a really high sensitive and specific sensitivity and positive predictive value, I don't know that I would have gone to the OR anymore. But all of our panelists said they would. So I think we need to get some clarity from all you guys and us so that our trainees know where to go.
The only comment I want to make is that the FAST scan, we've seen it be falsely positive, where it's actually a pericardial fat pad, and that causes a lot of confusion or consternation. Obviously, if you don't know and they're unstable, the choice is clear. But if you have time, then you can do it more. And in the setting of left chest, this is right chest, in the setting of left chest fluid, even if it was negative, it was slightly concerning. I would do some sort of a further study, whether it's a window or a thoracotomy or whatnot. But and basically to the other comment about the type of syndrome, did he get antipsychotics or something soon thereafter, and then the CPK started to rise, just as a question? And then I think Tanya has her hand up.
he did not receive any antipsychotics, and his CPKs were rising from like the very beginning. The first one was 300s, and the next one was like 15,000, and it went as high as 160,000 over the first 24 hours.
Okay. Tanya?
Just to add, like Jose, I appreciate your points, but I would say a trace fluid on pericardial fast is positive. It's not very positive, but fast is like either yes or no thing. So if you see fluid, although granted, maybe it's something else, maybe something else is going on, but it's literally sort of the risk benefit ratio in terms of if you have a negative pericardial window, that's okay. But if it actually is a cardiac injury and I've missed it, the patient can die. That's just mainly about the, after CT scan and stuff, and the question about the fast. Although I do want to mention that the false negative rates and false positive rates, actually more false negative rates of fast are really important to distinguish whether it's stab wound versus gunshot wounds. So we see, a lot of these, but mainly gunshot wounds here in Chicago. We don't believe the cardiac fast at all. And I think our friends in Colombia have shown that the false negative rate can be as high as 41%. It's a stab wound, so I can trust my fast a lot more. But if it's a gunshot wound in the cardiac box, and Kenji Naba has taught us the cardiac box for gunshot injuries, gunshot wounds, is the entire thorax. The false negative rate for cardiac fast is going to be 41%. So just something to keep in mind, but I love what Jose said about sort of keeping in mind the sensitivity and specificity of cardiac fast. Thank you.
And I would agree with everything that's been said. The other thing that Tanya said earlier, I think that's really important, and trainees need, and I think you can do a pericardial window pretty quickly, and knowing that there's not much blood in the left chest, and knowing also that you had a negative CT of the belly, you could then shift gears. And I think by then you probably would see that temperature rise. Take advantage of your colleagues with different expertises, and our anesthesiologists in the OR can be quite helpful, and also pharmacists, because there are so many drugs that our pharmacist gives a talk every year, and there's so many new drugs that come about, on the scene in the street that just cause all kinds of perplexing presentations that we've all got to be thinking about all these possibilities. I've never heard of the amphetamine, causing malignant hyperthermia, triggering it. But I'm glad you talked about that, because that's not an uncommon drug on the street.
You are muted, Randeep.
Oh, okay, I think we're good from the AAST side, Carlos, if you want to take from the PTS.
Sure, perfect. Before I present our presenter for today, I just want to give a very, very quick update. Dr. Marcus Hoffman, who is the chairman of the educational committee from the PTS, asked me to let everyone know and remind everyone that we are running the tax course on the PTS, on the PTS, the Pan American Trauma Society, which is a course that updates surgeons and residents about the most interesting topics in trauma surgery and acute care surgery. And the next tax course will be this Saturday at 9 a.m. until 1 p.m. We're going to discuss thoracic trauma, replating, when to irrigate the chest, subxiphoid window versus sternotomy, which was one of the discussions here, cardiac repairs, and other parts of the thoracic trauma. This course is free for PTS members, so if you are interested, just get in contact with us and we can help you join the session. So for this next case, we're going to have Dr. George Ibrahim. He's a PGY4 general surgery at Thomas Jefferson University in Philadelphia. And also as his faculty, Dr. Shiharsha Gumadi, I hope I'm pronouncing this correctly. She's assistant professor of surgery, division of acute care surgery at Thomas Jefferson University, Philadelphia. So Dr. Ibrahim, feel free to start and share your slides whenever you want.
Sounds good. Thank you. Hello, everybody. My name is George. I'm a research resident at Thomas Jefferson, interested in trauma. Today I'll be presenting a mangled extremity case. No conflicts of interest to disclose, and the learning objectives we're going for are understanding the different factors that impact the decision of limb salvage versus amputation, and discussing techniques for limb salvage and severe lower extremity bony injuries. So this was a 20-year-old female. She presented to the trauma bay after being pinned between two vehicles, which resulted in a partial amputation of both of her lower extremities. There was noted to be large volume arterial hemorrhage at the scene, so they placed tourniquets on both legs. She was still bleeding, so they placed a second tourniquet on each leg. She had prolonged extrication from between the vehicles greater than 1 hour, and she was taken to a level 2 outlying trauma center with access to transfer to level 1 trauma center as needed. On presentation, she was tachycardic, hypotensive, and normothermic. Her GCS was 14. If you straightened out her leg, she was able to move the toes on the right, but not on the left. The left lower extremity was appearing dusky and ischemic. The tourniquets were all removed, and there was no notes of arterial hemorrhage, just some venous oozing, and her MES score was 7. So this is an image of her lower extremities. And just some of the imaging that we got in the trauma bay. FAST was negative, chest x-ray, pelvic x-ray were negative, and lower extremity x-rays, which I'll show on the next slide. Extensive fractures of the lower extremities, tibia, fibula, calcaneal, and the left foot had a Lisfranc fracture. So this is the x-ray of both of her lower extremities. So I'm gonna pause here and ask, what would you do for the patient at this point?
All right, perfect. Let's start with Dr. Moncure.
These are horrific injuries. I think this patient needs to go to the operating room, and I don't know what the response was to the resuscitation, but if they're a little bit better, possibly getting CT scans before. But I would get my vascular team and my orthopedic team, and we'd have a huddle about this patient. Mangled extremities, I have a lot of respect for these. The side with the MES score of 7, where there's no neurologic function, I would really suggest to my colleagues that probably be a primary amputation. The second side, might be amenable to fixation, possibly a trial. But again, I've seen a couple patients in the last couple of years that have died as a result of us not being aggressive enough and us having too much in our armamentarium to kind of fix these extremities.
Dr. Ibrahim, Dr. Frisbee asked a question in the chat, so he wants to know how long has the trauma been from the accident to the hospital? Do you have this information?
So it wasn't entirely clear based on the chart. I know it's probably around 2 to 3 hours because the extrication took greater than 1 hour.
Perfect. Dr. Bagaria, how do you guys manage this in India? Do you use the same mesh score?
Yes.
What would be your takes here?
So I absolutely agree with Dr. Monco's comment that probably in majority of these patients, amputation would be a go-to strategy. As far as the MES score is concerned, we do use MES score along with the other very frequently used score, which again was proposed by Indian Institute only, that GOSIS score, Ganga Hospital Injury Severity Score, which is again a score to decide about the amputation and limb salvage in lower limb injuries, especially the Costello-Anderson class 3C and 3B injuries. So these kind of the Ganga score is very predictable score, and it is very frequently used all across the world also, and it has shown a good accuracy about the prediction as well as the amputation decision. In this particular patient, like you have said, already 3 hours has gone. We consider that after 3 to 4 hours, the amputation as well as salvage rate in vascular injury especially don't differ. Whether you do the vascular injury or not, the amputation rate remains the same. So probably at this point of the time, vascular repair is out of the sight, and the best strategy, like Dr. Michael said, is the go with the amputation.
All right. Dr. Zacharyson, we're talking about the MES score and the injuries to the extremities, but why don't you give some comments as well, not only specifically to the extremity injury, but also what else do you have to be very aware of this kind of patients, and what else can impact negatively the chances or the rates of reperfusion the limb?
Thank you, Carlos. And George, interesting case so far, horrible case. One thing I just wanted to, before addressing those questions, jump back at and just to point out, and because we sort of skipped over it a little bit, but just again for the any trainees on the call, just to remember that this patient has a blood pressure of 80, George, I think it was, like initially. Probably blood loss from the extremities, probably just, you know, controlled now with the tourniquets, the double tourniquets. But I would just make sure this is still blunt trauma, and just make sure you've done your thorough primary survey, and make sure there's no torso trauma. People, you know, discussed, and I love Michael's comments as well. They discussed, you know, should you scan or not? We do tend to, if we're worried about you know, if it's like we're worried about polysystem trauma, and that depends if the patient can tell you a history, if there's witnesses at the scene, that type of thing. We will do like at least, you know, the FAST, chest x-ray, all the things, plus or minus scanning if we really can't get that history, just to make sure there's nothing going on in the torso before I zoom in to the extremities. Now, in terms of making that decision, is it salvageable or not? The MES score is good. It's not perfect, it's not great. And I'll be honest, you know, very rarely, and I think maybe my colleagues will share with me, like we very rarely like take out the calculator and necessarily calculate it in the OR, although you can, there's many calculators online. But it is that very nuanced, you know, like what Michael was saying, that nuanced conversation you're having with your colleagues. So a lot of factors depend on, you know, the injury itself, Carlos, and then the patient themselves as well. Are they young? Are they old? This is a young patient. Do they have diabetes or, you know, systemic risk factors? Do they have peripheral arterial disease, anything like that? Are they a smoker? And then, you know, you have your local factors in terms of what's the neurologic status, what's your vascular status, is there any sensation, is there any movement, that type of thing. But these are very, very, there's kind of no right and wrong answer a priori. I think it really is important and incumbent on teams to get together to have that multidisciplinary conversation. And again, to the point that was made earlier, resist the temptation of doing everything. Like you can revascularize, we can do this and that, because that can be, it can literally be hell for the patient, to be honest. And also, none of those conversations or decisions have to be made in the moment. Right now, we're just doing damage control. And the damage control is, does the limb come off to save the life, yes or no? Or is there something that we can do to temporize, to bring this patient back into physiologic normality, if you will, and then have these conversations with time? Are there, you know, other things we have to assess? Do we have an adequate neurovascular assessment? You know, with tourniquets on, you're not really going to have that. So there's other things we need to fix at this time within the damage control surgery approach, and then have that multidisciplinary conversation. Thank you.
Perfect. Dr. Ibrahim, you can move on.
Thank you. So kind of like giving the whole picture now. So the primary and secondary surveys were completed. She was intubated both to help progress her care and as well as a state of extremis from her pain. MTP was activated for hemorrhagic shock, and she was noted to be a responder to transfusions and stabilized with blood. She received ceftriaxone and metronidazole for Gustilo-Anderson grade 3 open fractures. And then, given that she had stabilized with blood administration, we decided to go to the CAT scan prior to going to the OR. So CAT scan from the head to the pelvis didn't show any significant injuries, and we decided to get a CTA of the lower extremities to sort of get a better idea of any vascular injuries. And then while we were on the way to the OR, the orthopedic surgeon was consulted to join us. So I have a little clip of her CAT scan here. So it goes from the femorals, the SFA, coming down into the POP. The TP trunk was intact. And it's at the level of the fractures that you begin to lose signals. So around here. So at this point, the patient is we're committed to taking the patient to the OR. She is stabilized. The key thing to keep in mind here is that she is 20 years old. So do you decide to do an amputation? Do you try to do a limb salvage? And if you try to do an amputation, do you do an AKA, a BKA? And if you're going to try to do limb salvage, how do you approach that?
All right. Dr. Zachrison, do you want to start with this one?
Sure, that's fine. I think for limb salvage, these are avascular limbs. I apologize, George, I missed out. The CT scan was not on the way to the OR, or was on the way to the OR?
It was on the way to the OR. She stabilized with blood, so we took her to the CAT scan first.
And you took the tourniquets down?
Tourniquets were down during the scan, correct.
Okay, perfect. Sorry about that. Thank you. So you're dealing with avascular limbs, huge, orthopedic reconstruction needed. This is going to be very difficult. But again, at the first OR, typically, if really there's your vessel is transected, you have no neurologic status in terms of there's no motor, there's no sensory function, and you just really have kind of a foot. And I think your photos demonstrate that too. If you have an extremity limb just sort of hanging on by soft tissue, there's really not much you can do. But with that said, you can bring in, as you mentioned, your orthopods into the OR. You can bring in your vascular surgeons into the OR. Definitely have conversations. And, even if it's a decision of like, well, it's a young person, this is going to be life altering for sure. If it's kind of something on the fence, I still call, like, I'm a professor of surgery, but still young in my career, but I still call my boss in the middle of the night, and he's like gracious enough to pick up the phone and all that. But I'll call other trauma surgeons. I'll call my backup trauma surgeon as well, and just get more eyes on it. If people are kind of on the fence about, do we just transect the soft tissue, deal with the bleeding, and again, do that damage control route, and we know it's a clear case of non-salvageable, or it's like, we're not sure. If we're not sure, then we might just, ligate blood vessels, see what we can do, irrigate it copiously, make sure there's no septic concerns at this time, and then meet within the next 24 hours, have ample antibiotics on board like you did, George, and then say, let's discuss all in a group, let's do another physical exam, let's come back the next day, let's involve the patient, the decision-making, the family members and all that, and also PMNR, rehabilitation medicine, but having a clear discussion with patient and family that sometimes limb salvage is worse than amputation. And I think, Michael, you mentioned even, that could lead to death, in fact, but that's interesting. I haven't, personally seen a case of that, but it's not kind of this panacea of like, do whatever you can to salvage the limb. But I would say you can buy yourself time if it's not a clear-cut indication of, the limb has to come off because the patient's going to be really sick with this.
That's a great comment. Dr. Moncure, any other thoughts on that, on the approach for this case?
No, I would agree. And that limb where it looked like the lower leg was hanging on by a thread, I think that needs to go. And that would be a guillotine, probably at the level that you could preserve a BKA, which could be functional, and possibly if the other side is vascularly intact, if we can do things to wash that out, reduce, I totally agree, reduce the likelihood of any kind of septic complications, and do whatever you can, X-fix or what have you on that other side, and then have a good discussion. And I would agree. I think you have to make a plan that with these type of injuries to go back probably every 24 hours at least until you're sure that things are good and the patient's stable, and that letting the patient and the family know that at any point the injuries are severe enough that it could end up with an amputation on the other side or even higher up on the side in which we did the guillotine. But it need to be very clear about what's going on. The cases that I've seen, it's that they were able to kind of get away initially with limb salvage. However, there were other things that went on that caused sepsis and ascending, sepsis from the extremity, and that's really a nightmare and sometimes extremely hard to get a handle on. We actually, yeah, it's something that I think about a lot.
Yeah, definitely. Dr. Bagaria, any other thoughts?
So we can discuss many things theoretically. We can do this, you can do that, but for all practical purpose, this patient is going to be undergo amputation. Unfortunately, we have to perform a lot of amputation, at least 3 to 4 per week, because of lots of road traffic accidents we encounter. As far as the decision about the BK or AK is concerned, in our practice, these wounds are dirty. They are going to infect in majority of cases. So as of now, like Dr. Michael said, the guillotine is good enough. Do proper lavage and come after 24, 48 hours, and let's see how the stump behaves, and that time further debridement and then wound management, or if everything goes fine, then the maturing of the stump can be performed.
Perfect. Dr. Ibrahim, you can move on.
Thank you.
And I think one other thing, when you have blunt trauma causing these injuries, you've got to remember that there's tissue injury that may not be perceptible initially. And that's why that 24 or 48 hours is really important. Things that weren't obvious in regards to at the initial presentation, looks like frankly dead tissue, later on. And so that needs to be really vigilant about that.
Dr. Ibrahim, Dr. Pasquale is asking in the chat if you guys also gave antifungals or only the antibiotics.
She only got antibiotics.
And I think Dr. Frisby had a question in the chat as well about if the limb was neurologically intact.
The right foot was neurologically intact on initial presentation. The left foot, she wasn't able to move any toes or really do anything with that leg.
Thank you.
All right.
So we took her to the OR. We reduced her fractures and explored all 3 of her pedal vessels bilaterally. So once reduced, all the vessels had palpable pulses, and an intraoperative ultrasound didn't show any obvious thrombosis or dissection flaps in the vessels. So at that point, given the fact that she had flow to her legs, to her feet rather, the decision was made to go with a biplanar tibial calcaneal X-fix, and then we placed additional pins into floating fragments for further stability. And then she was transferred to our quaternary care center for further attempts at limb salvage with a orthopedic traumatologist, as well as plastic surgery for assistance in reconstruction. So these are the images pre and post X-fix. And then these are the actual intraoperative images after her X-fixes were placed. So she came to our quaternary care center, and she was still intubated at this time. But we had a discussion with her family, and we also weaned her pressors, her sedation, and wanted to discuss with her the decision to amputate versus try to proceed with further attempts at limb salvage. We discussed that limb salvage would be a long, challenging road with PT, OT, chronic pain, and a lot of other challenges, but they decided to go ahead with limb salvage. So we spoke with our trauma team, and at this point, we wanted to sort of, they felt she was best served with changing the X-fix to intramedullary nail fixation. So they moved both X-fixes and placed IMNs for both legs and was non-weight bearing on the bilateral lower extremities at this point. So the question I have for you, which is the other part of this case, is this patient now has pretty extensive wounds from her injury. So how do you proceed with soft tissue coverage for this patient?
All right, let's start with Dr. Bagaria this time.
So if I prefer to salvage the limb, probably at that point in time, I will just do the debridement, and later on, I will put some wet therapy And once the wound is clear, then probably I will drop in my plastic surgically to do some local flap or any other flap suitable for this particular patient, provided that we are able to salvage the limb at least for 1 week or so. And we are continuing with that path only.
All right. Dr. Moncure?
Yeah, I would agree. I think a myocutaneous flap is going to be, this patient will be best served by with the amount of soft tissue injury and the possibility of reducing infection. But I think the thing that my colleague just said is really important. Jumping into that too quickly might be putting that patient through an unnecessary surgery because there still could be other soft tissue loss that occurs, and it could make it even more obvious that this patient might need an amputation. So I think that week would be probably pretty reasonable to wait for.
Nice. Dr. Tanya, if we are trying to get this done later on, what would you do to cover this while you don't get the final procedure?
You know, I wouldn't, because I can't flap. I don't do soft tissue. I mean, what I can do is, you know, to Dr. Frisbee's point, split thickness skin grafting, but these are very contaminated wounds. You know, contaminated, they're a risk of bacterial infection, even though they look to the eyeball now. You need to get, like, I know our plastic surgeons locally, they like to get like quantitative, you know, bacterial counts and things like that. So really, we're going to do serial washouts, for example, and a lot of vacuum assisted closure type devices for the time being. But really, a lot of this is still that very, very important multidisciplinary conversation. And we do get our plastic surgeons involved early, not for anything, but sometimes they're actually even helpful, or sometimes, you know, it's really important to think about, even if you're amputating, to remember to sort of put the nerves on stretch so that when you cut them sharply, they're retracting. Like, there's little things of, like, even within the amputation, even though you're still sort of doing damage control, it's just good information to have about, like, how much muscle can you go in. And I love the comment about your muscle is going to demarcate over time. You know, it's not going to be like just resecting it in the first OR and then you should be good to go. So you're probably still going to be resecting muscle at this stage, and maybe even into the week out. But in my hands, I'd really be deferring to our plastic surgeons. My hands, what I can do is conduct the orchestra of all the subspecialties and make sure we're all communicating together, which sometimes doesn't necessarily happen, but push for the OR, get OR time if that's holding up plastic surgery or orthopedic surgery or something like that. And then also nutrition, you know, watching for sepsis and just making sure that this catabolic patient has excellent nutrition. I don't know about your institutions, for everyone on the call, but something that does, as a side note, Carlos, happen to these patients is you book them for the add-on case, for the washout of the soft tissue injuries, or we want to tighten some of the extra screw, who knows, something like that. So they're NPO for the whole day, even though they might still be intubated and all that silly dance we have. And then they're canceled at the end of the day because more gunshot wounds come in or whatnot. Nutrition has to be very, very important for these patients, simply because of the amount of, like, soft tissue injury and extensive crush injury to the extremities. Thank you.
Yeah, that's a great point. In the interest of time, I'm going to pass again to Dr. Ibrahim so he can move on with the case.
Yep. So we had our plastic surgeons were on call we're waiting for the OR for that patient to assist ortho with the closure. Discussion with the ortho trauma surgeon. So they didn't actually resect any skin at the initial surgery. And the team felt that she had been adequately lavaged both at the initial surgery, and they lavaged her again with an additional 6 liters at the IMN surgery, her second surgery. So they felt comfortable closing her legs, keeping her on antibiotics, and watching closely for signs of infection. So that's what we proceeded with. And these are pictures of her lower extremities after the wounds were closed. And then going back to sort of the initial scan, she had some pedal injuries noted on the x-rays. And now that we had gone down the route of limb salvage and had sort of stabilized the long bone injuries, we got a CT of the feet to further characterize the injuries. So the right foot had a non-displaced navicular avulsion and calcaneal fracture that was managed conservatively, and the left foot had operative fractures, including a first metatarsal shaft fracture, and then fracture dislocations of the 2nd to 5th tarsometatarsal joints. So she went back to the OR because of the amount of soft tissue injury she had to her left foot. The ortho team didn't feel like she would be well served by doing an open repair. So instead, she underwent wire fixation. And then this is a picture of her postoperative wire fixation. So just notable milestones from her admission. She was extubated on post-injury day 3, was discharged home with skill therapy, and her hospital course was a total of 20 days. Currently, she remains non-weight bearing. She'll probably need a midfoot fusion in the future, and we're hopeful that she'll be able to walk in the future, but unlikely to really engage in any high energy sports or running in the future. I'm happy to take any questions about this case.
All right. Thank you very much. Very, very interesting case presentation, and also very interesting discussion about the nuances of amputation and limb salvage. Let's go for a round for panelists to make sure that everyone has final comments before we move on with Dr. Pasquale and Dr. Jawa again. Dr. Moncur, do you have any final comments?
Great case. I've got to probably get rid of the PTSD from those couple of patients that I had because I would have probably been one part of that team that would have been pushing for amputation. But yeah, great management.
Dr. Bagaria.
Yeah, I agree with Dr. Michael that kind of unusual process, I would say the path was taken by the managing team. At least in my center, I would have taken that and we would have opted for the amputation, upfront amputation. The one thing which I would like to add that in few patients recently, we have used the IPOP, which is the immediate post-operative prosthesis, which has given very encouraging results. So probably that is one thing considering her younger age and affordability, financial affordability is again a very big challenge in this part of the world. And if they can do that, then probably immediate post-operative prosthesis is one thing which we would like to obtain.
Interesting. Dr. Zachrison, any final comments?
Thank you. That was a really interesting case, George. Thank you. And I think it highlights some important points. It's important pre-op, especially with a patient of a GCS of 14, if you can get a careful neurologic exam, like neurovascular exam on both your extremities prior to going to the OR. Another thing that I learned from this case as well is something to keep in mind is you might have a CTA that shows one thing with the tourniquets off, but in the OR, check and double check and triple check. Check the vascular system yourself, get your ultrasounds out and things like that. And those important points that my co-panelists kindly mentioned about having your multidisciplinary teams involved. Personally, I think it seemed a little aggressive. I'm very conservative surgically. I'm very liberal, as my friends know, socially, but very conservative surgically. I probably would have done the VAC, even the IM nail kind of surprises me. I would be very, very concerned about sepsis and probably gone the long route, but really interesting case, and congratulations to your team for a great save. Thank you.
Can I say
Perfect.
I think
Of course.
What was made earlier about booking the OR on a daily basis for this patient hold a spot, because I've seen in that patient, where there wasn't a spot and people decided, oh, we'll just go tomorrow when we have a good time, because you've got those multiple teams together that could delay management. So I think it's not overkill by putting them on in case things turn for the worse.
Nice. Dr. Pasquale, the floor is yours. Thank you very much.
Yeah. Thank you very much, Carlos, and thank you, Randeep, for moderating the session. Thank you to our amazing presentations and very thought out comments by our panelists. If anyone is interested in presenting cases, please reach out to Carlos and I, where our emails are in the different flyers. And thank you again for joining us today. See you next time.
Thank
you,
you.
everyone.
Take care.
Thank you, Jay.
Thank you, guys.